So, welcome everyone. I'm glad those of you who are here made it out. Want to just welcome you guys to the space. As most of you already know, this is InVirtuo. We are a completely virtual reality medical education platform, and more so a community for people who are interested in regenerative medicine, pain medicine, neurosurgery, and really anything in the medical education to come and discuss and learn and share ideas and play with models and so on. So we're pretty excited about our guest today. She is our first neurosurgeon to come on stage, so that is an honor in and itself. I want to introduce Dr. Heather Pinckard-Dover out of West Virginia. So Dr. Pinckard-Dover is an Associate Professor of Neurosurgery at Marshall University in Huntington, West Virginia, since August of 2021. She completed her undergraduate with Bachelor's in Science and Neuroscience at Baylor University in Waco, Texas. She received her medical degree from the University of Arkansas for medical sciences in Little Rock, Arkansas, where also she then completed her residency in neurological surgery, which, as you guys know, is 7 grueling years. She went on to do a stereotactic and functional neurosurgery fellowship at the University of Florida in Gainesville, Florida. Go Gators, that is my alma mater. And she now enjoys a full-time general neurosurgery practice with focus on functional neurosurgery while being a loving mother and wife and running a nonprofit. And she's editor of social media for the Journal of Neuromodulation. So everybody put your virtual hands together for Dr. Heather Pinckard-Dover. And without further ado, the stage is yours.
Thank you very much. Thank you for having me. This is quite an honor and pretty cool, I have to admit. So tonight I wanted to talk to you about neurosurgery alphabet soup. Probably the most common question I get from other doctors is, "What'd you do today?" I'm like, "Oh, I did an ACDF and a lumbar discectomy," and they're like, "What does that mean?" And so today I wanted to kind of just go over, what do all these letters mean that we just ramble on about, and what did the patient actually get? So we'll start at the top and work our way down. So the first one is the anterior cervical discectomy infusion that we like to call an ACDF. You'll probably hear that one the most. So for this, we start at the front of the neck here. So we go here to the front of the neck and we incise the disc. We take it out. We take a little spacer like this. Click on it.
Bring it closer for you. Here you are.
Thank you. So this is still pretty large for what we would do with it, but basically we would put that to that disc space. And then this plate over here.
Get out of your way.
Sorry.
You want me to resize that device here for
Yeah,
you?
if you can get it to go any smaller. I tried to make it go smaller.
Let's see, move that. This plus here. I shrink it for you here.
So as you move in the spine model.
Yeah, I see that. That's like that. So we'll just
That's
make
fine.
this
That's
bigger
close
then. How
enough.
about that? Whoop.
Okay. Well, let's bring it way down here for me.
Let's do this.
Oh, here we go.
I think it pops up when we push it into the ground like that.
Got it there.
Oh. Learning curve. There's a whole different stereotactic surgery.
Oh. Down. Okay. All right, so this, I think you get the idea here. So
Yeah.
we try to put that inner body into this disc space. Side of the spine now. Okay. So I would approach from the front. I would take out this disc. That spacer would go in there. If you want to stick it in there, get to it. There we go. So it would go in like that. Still a little bit big. And where did my plate go? Oh, there it is.
Right here. Oh, almost got it.
Took off with it.
Come on back around. There we go.
Here we go.
This is the learning curve we
All right.
didn't anticipate. If I can try and grab it, put it so, and then I'll
Looks
hand
like
it over to
maybe I
you.
didn't make my play space big enough. Here we go. Basically, it would go like that, except for these screws would stay inside of the vertebral bodies. They would not go outside of it.
I see.
All right, so that's an ACDF. Place screws here along the facet, and we'll go this way. At C2, it's more this way. So we'll put screws into the posterior part of the spine. Put her back down here. Ah, this is really... All right, so said screws go on both sides like this. And then we take this part of the lamina and the spinous processes off to decompress the spinal cord. So the reason we do that is for patients that have cervical disc or really strong osteophytes or ligamentous hypertrophy in the back that's causing pressure on the spinal cord. There is such a thing as congenital stenosis, so they have a very small canal to begin with, and then if they have any extra degeneration on top of that, they can be at risk for causing compression of the spinal cord. So that's the PCDF. Risk, bleeding, infection, damage to the spinal cord, basically the same things. But we are no longer messing with the trachea or esophagus, so those risks are lower. Posterior lumbar decompression. So
I'll unlock it for you. Just
okay.
a sec there. Go.
For this, we'll take the spinous process off and just the lamina. You want to make sure you stay here just medial to the joints when you do the decompression, or else you risk causing instability. This part here is called the pars. You want to leave that alone too, because that's what connects your levels together. So you just take off that part for the decompression. Usually that's due to degenerative disease with hypertrophy of the ligamentum flavum that's causing pressure on the spinal cord, or a large disc herniation, but the patient has got some risk factors for going into the disc space. Okay. Risk include bleeding, infection, damage to the spinal nerve roots, causing weakness, paralysis, sensation loss, bowel bladder dysfunction, sexual dysfunction, spinal fluid loss. Are there any questions so far?
I have a question. So you were just talking about, the laminectomy and needing to stay medial to the joints because of the risk of instability. At what point during your surgical planning do you know that you're likely going to end up with instability and decide to fuse? Sorry if this question is a little early.
No. So usually if the patient doesn't have any evidence of instability or a large disc herniation where you feel like you need to go into the disc space, then you're just going to do the decompression and try to stay medial to the joint so as not to cause instability. And especially in elderly patients where you want to do the minimal necessary to get them through, that's typically who we are doing more just a straight lumbar decompression with no discectomy or anything.
Gotcha.
Okay. And they're also the ones who get the lumbar stenosis with the neurogenic claudication. So that's that burning
Mhm.
pain that goes down the back of their legs when they're walking more than about 10 feet. All right.
Right.
Same question actually, but also with foramen anatomy. Where's the threshold where we see laminectomy, laminotomy, foramen anatomy, and the risk of instability there?
So if the patient's having more radicular symptoms than neurogenic claudication, then you may do a foraminotomy whenever you do the decompression. So you'll take the lamina off and then you'll take the kerrison and you'll bite underneath the bone of the pars and widen out that foramen for the nerve root to give the nerve root more room. Usually I pass a probe through there and make sure that my probe can freely pass through there without compressing the nerve root with when I've decompressed it with a kerrison. But that's for radicular symptoms. You'll do the foraminotomy. Okay, great questions. Anything else?
I have kind of a general question.
Uh-huh.
With all these different approaches, when you're actually getting down, to bone, um, are there any thoughts on? I always hear people talk about, oh, there's multifidus atrophy after surgery, and there's disruption of the thoracodorsal fascia, and all these things. What are your thoughts on that, and how has it evolved, with time?
So for a lumbar decompression, I'm going to have to open up the fascia. So I open up over this, I open the fascia and literally hug this bone and try to peel the muscle off of the periosteum here as much as possible. But a lot of times
Mm-hmm.
you're cutting that muscle fiber because it doesn't just peel off as nice as you'd like.
Mm-hmm.
And so that's why you get that atrophy there of
Mm-hmm.
that muscle is we literally have to take it off of its insertion sites here along the bone edges
Mm-hmm.
to get our exposure. Now, if you're just doing a decompression, I try really hard not to get into the capsule over the facet or pull the muscle too much over the facet joint so as to not cause facetogenic pain by disrupting that capsule and that nerve root
Mm-hmm.
or the median nerve go into it. Um, so yeah, I think that
I see.
maybe answers your question. The next one, we have two different options that does take into account that, and that's the lumbar discectomy. So you can
Mm-hmm.
do a lumbar discectomy by doing the lumbar decompression that we just talked about, and you move the thecac to the side, and you can get down to the disc that way and take out the disc fragment that's herniated out.
Mm-hmm.
But like you said, that opens up the fascia, we peel away the muscle, and it tends to cause some atrophy. So when we're just going to do one or maybe two levels, we actually will make a smaller incision just to the parasagittal of midline and pass a dilator down to the bone here. Usually
Mm-hmm.
like right here, we'll try to park it, and then we dilate up with other dilators till we get to a 13 millimeter tube. And so we're going just straight through the muscle fibers with those dilators, trying to minimize the muscle disruption with that. Then once we have the tube down, we bring the microscope in and take a drill, and we'll drill off this part of the bone, trying to still stay medial to the facet. And then you'll take your kerrisons and bite out where the nerve root comes up here and comes down there. and then you go to the disc space and you move the thecal sac over, go into the disc space and clean out the disc fragment that has
I see.
herniated out.
I see.
So
then-
that's the reason if you ever hear minimally invasive or
Mm-hmm.
micro discectomy, that means that they use the tube to go down there and the microscope.
I got you. And then for, this is indicated for disc herniation, but I would imagine like if you had someone who's got sequestered disc material or it's extruded or what have you, that would make a lot of sense. Where do you kind of draw the line in terms of, herniation or bulging versus protrusion, or what's the starting point or the cutoff point, I should say?
Well, I'll use this for a bulgingness that's causing clear radicular symptoms, or causing lateral recess stenosis, traversing a nerve root, that does not show any evidence of instability. If they show evidence of instability with flexion extension x-rays or in the symptoms that they describe, then I'm going to think that they need a fusion. Or if they've already had a discectomy at that level, sometimes you can get away with just doing a second discectomy, but most of the time you're going to end up fusing them if they've already had a discectomy and then they have a recurrent disc herniation.
I see.
Hopefully that answered your question.
Yes,
Yeah,
it does.
definitely.
Thank you.
Yeah.
All right.
Cool.
So, yep. Okay. So that's the lumbar discectomy. Again, we're moving the thecal sac over, so there's a little bit more risk of spinal fluid loss with that and injury to the nerve root that's going out. So we bring the microscope in for that case most of the time because we're just doing one level. Then we have PLIF, posterior lumbar interbody fusion. So this one and the next one is really just surgeon preference as to which technique you prefer to use, and it really depends on how you trained. Technically for a posterior lumbar interbody fusion, you're going to do the same cuts that you do for a lumbar decompression, and that you just drill the troughs down the lamina and take that piece off, and then you move the thecal sac to one side, do your discectomy, and you're going to put an interbody graft in like that guy, without, yeah, that one.
I think if you want to manipulate its orientation, it's best to manipulate it above like kind of far from the spine. So like I'll grab
Hold
it.
on, let me lock this spine.
There we go.
All right. And if you,
I pinned the spine.
oh, very nice. So if you reach out and grab it with all 3 fingers, there you go.
There we go. All right. So then we would place that through that laminotomy into that disc space there. And then often with a PLIF, you're going to do that on the other side too. And then you're going to put the screws and the rods, which we have over here.
Here, Mo, let's lift the spine up a little bit.
Yeah. 1 second. So we're just going to lift the spine up for you, orient it a little bit better.
So ignore the,
There, it's pinned.
Perfect.
let me, smaller. I'm doing wrong, guys. I'm trying to make it smaller. There it goes.
There you go.
Okay. Yeah. right. Then these screws would go like this. So they go into the pedicle, down into the vertebral bodies. And then those inner bodies go into the disc space. And that's a PLIF. So when you do a PLIF, you're not disrupting the pars, you're not taking out the facet joints, you're just really doing that medial decompression. So, but like I said, surgeon preference. It has the same kind of risk, except for now because we're trying to fuse, you have the risk of pseudoarthrosis or it not fusing, and then adjacent level disease due to changing the biomechanics. So then you have, the TLIF, the transforaminal lumbar interbody fusion. This is the one that I technically prefer. And for it, you will take the pars here. So I make a cut along the pars, I make a midline cut, and I take this inferior facet, and that whole fragment comes off. It's called a gill fragment, if you ever see that. You take that off, and I typically will do it on both sides, and then you can really see the nerve root coming out on both sides there, nice and decompressed. You go into the disc space, you put an inner body into the disc space, and you try to get it as midline as possible. And you've got a better chance of doing that with a TLIF versus the PLIF because you can get out here in the foramen with the lateral to medial trajectory with your inner body and get it across the midline. With the PLIF, the reason you end up doing two is because you can only have a straight trajectory with it, so you're going to only jack up one side of the spine. So typically you'll put one on both sides so that you jack up the disc space equally on both sides. And that's the difference between a PLIF and a TLIF.
Got it.
It's just surgeon preference as to what you prefer to do. And then you put the screws in the rods like you do for the PLIF, and then we usually put bone along the sides of the rods to help promote fusion. Okay.
Bone
Any
like
questions
DBM?
It's again surgeon preference which you like to use. I use Magnifuse, which is a sock of bone. So it has like morselized bone in this little sock that keeps all the bone nice and neat along the side. It's just easier.
Interesting.
All
Very
right.
cool.
I'm sorry, did you say a sock of bone? Like SOCK?
Yeah, I don't have a better word for it. It's literally like this little mesh bag.
Oh,
It's like
okay.
a
All
little
right.
mesh bag with morselized bone in it, and we just call it a sock of bone. I don't know how that got started, but
All right.
that's
All
what we
right.
call
Fair
it.
enough. Thank you.
All right. So then next we have the XLIF. And we unpin the spine quick.
All right. Unpinned.
Okay. See if it's going to let me. The spine. So for an XLIF, you're going to actually come from the side. You're going to make an incision on the patient's side here and put a tube
Oop.
down. Okay, we
Sorry.
can pin it now. Go. So then you're going to put a tube down and you're going to actually put the dilator tube straight down to the disc. And then you dilate it up and you widen it out. So you're working through a tube, kind of like the micro disc again. So when we do that, of course, we're going through the psoas muscle to do that. So patients often have hip flexor weakness after the surgery or pain just due to interruption of the psoas muscle that gets better in like a week. But anyways, you dilate down. We have nerve monitoring so we can make sure that we're not actually catching one of the nerve roots of the lumbar plexus as it's going down. And so then once you're here, you take your 15 blade and you open up the disc space in your pituitaries and you clean out the disc space. And then that's where this guy.
I'll hand it to you here.
Okay.
Sometimes it's like, once it gets too close to the spine model, it kind of gets a little confounded. Let's see. Now we're all trying to touch this thing. Here, Mo, unlock the spine, push it
I
down.
don't know.
Let's get this thing out of its spine force field.
I'd say you guys
It's
did
like
a pretty good job with this fusion. Nailed it.
Go like this. Now you can grab that. Yeah, move out
Okay.
of the way. Now you can grab
Except for
this thing.
now I'm like underneath the spine. There we go.
I like this, I guess. Bring it
Yep.
out of your way. And then let's pin the spine.
And
Pinned. Okay.
Okay. My goodness.
Where'd
How
you
did
go?
it make me jump that far?
oh.
Don't ask me how I jumped that far. I don't know.
So, you mind if I take a stab at it?
Sure.
All right. I'm just going to grab it like so.
I think you can.
I'm going to walk up here. And I'm going to just set. Oh, I just walked into my refrigerator. Hold on. There we go.
That's
I'm
my
gonna just
problem.
set
Is
it.
my space isn't big enough. There you go. Nice. It's like you've done this
Hey.
before. So this is it. This is an XLIF. It's done from a lateral trajectory. And so this one versus the next ones just depends on what company you're used to using. So XLIF is technically from the Nuvasive company. They patented this technique and their instrumentation for that. Risk here, obviously going through the psoas muscle, you cause hip flexor weakness. You can damage one of the lumbar plexus nerve roots, causing weakness, paralysis, sensation loss, bowel bladder dysfunction. Just depends on how high up you are. And then you can also still get into the spinal canal when you're doing your discectomy and everything. So you're using X-ray to try to tell you where your anterior and posterior borders are. But this is a round object in a 2D fluoroscopy, right?
Mm-hmm.
So
Yeah.
there
Right.
you could be off. And so there's always risk that you could get too far posterior and get into the spinal canal and injure the thecal sac. But you want to try to get as far back as you can because that's really where the compression is from. Because you don't get much direct decompression of the nerve root, most people who do an XLIF will back it up by going posteriorly and putting the screws and rods posterior and decompressing from the back as well. So this tends to be for somebody who has like a scoliosis where they're bent over to one side and you're trying to get a large graft across the disc space and straighten back up that curve. So you go in from the side where the curve is down and you jack it back up on that side by putting a big graft all the way across it. Does that
What are
make
some?
sense?
Yes. What are some general? So what you were talking about watching for not going too posteriorly and so on reminds me of when I'm doing kyphos, and the whole thing is just check your medial lateral so you make sure you're not going too posteriorly. And I just made me wonder. I just had a patient that I did a 3-level kyphoplasty on, and she is scoliotic like I've never seen before, which really made getting the floor images quite challenging.
Right.
Can patients who are osteoporotic get this done, or can patients who are osteoporotic and have had vertebral augmentation get this done?
Yes, they can. But especially if you have an osteoporotic patient, you don't want to trust just this lateral plate with the screws. You definitely want to back them up with posterior screws and rods. And I warn all my osteoporotic patients when I put, all my patients really, when I put the screws in, if it doesn't have good purchase because their bone's too soft, I may have to go to the next level. sometimes even when you put those screws on, the bone's so soft, the pedicle just blows out trying to put the screw down, or breaks when you're doing your decompression, exposing your screw, and then you have to go to the next level because you want to finish somewhere that you have really good purchase with your screws, or else they're going to fail.
That
Your
particular
instrumentation will
blowout that,
loosen and
oh goodness. I never really thought about, blowing out a pedicle. I mean, I've worked with wood before, and yeah, you drive a screw into something and then it breaks off a corner or busts, along the grain. Is that because you're using, threaded screws, or is it just the volume of this device going in there? Because, I've the last kypho I didn't even have to mallet. I mean, the trocar just pushed through pedicle all the way into the body.
So we're usually using some kind of stereotactic navigation that's trying to show us the trajectory we should be using down the pedicle, but we're trying to put a 5.5 or a 6.5 screw down something that's only 6 or 7 millimeters wide. So if your navigation is off by a millimeter or two, you can actually be skiving kind of on that cortical bone already. And if it's real brittle and easy to fracture, then just the force of putting that screw down can cause it to fracture off. Or we typically put our screws in and then we do our decompression to put the inner bodies and stuff in. And when you take that facet joint off, hammering pretty hard and leveraging stuff off, and sometimes the pedicle will fracture just in that act. And then you're and you have to go to the next level. So
Wow.
Yeah.
Interesting.
that's how small neurosurgical procedures turn into multi-level fusions.
Yeah.
I've always wondered about that. Yeah.
So it just depends on what happens there in the surgery. So this is the X lift where you go directly lateral. Now, our next one is the O lift or D lift. So the oblique lumbar interbody fusion or the direct lumbar interbody fusion, just depending on which company you're working with. So for this, you're going to make an incision on the abdomen, actually, and you usually have an access surgeon, a vascular surgeon or a general surgeon who's used to doing the access. So they make the incision on the abdomen, on the lateral side of it, and then they will actually move the peritoneum out of the way and go between the vein, the inferior vena cava, and the psoas muscle. So you're not at as increased risk of injuring the psoas muscle or the lumbar plexus. You're going right in between that. Let's see if this thing will shoot up just a little bit. So you're going to be coming in more at an oblique like this to do the discectomy. And then you're going to put the inner body in. This time it's just going to be a little more rotated this way. So you can imagine coming in an oblique, that puts you at even increased risk of not really knowing where your posterior wall is, and risking injury getting into the canal. So you don't really get a lot of direct decompression with this. You get more what we call indirect decompression by really jacking up the space and opening back up that disc space, which will open up the foramen posteriorly and hopefully create enough space. But if you're worried that it hasn't done that, then you can always go posteriorly and put the screws and rods and do the direct decompression from posterior. Okay. But this one has risk of injury to the bowel, because, like I said, they're moving the whole peritoneum out of the way. So the access surgeon could injure the bowel in there. And then the ureter actually runs close to where this operation is. So there could be an injury to the ureter during this operation, and you might not always see it. If you see yellow fluid, you're really concerned, but most of the time you don't see it. And then the patient's not doing well, having trouble peeing postoperatively, and you have to get a CT of the abdomen and call urology because you're concerned that you've injured the ureter somehow during the surgery.
Interesting. So I imagine that because you have to call on, another surgeon to be there for this surgery, that this is done less frequently, correct?
It just depends on where you're at. So, I mean, here my surgeons really, my partners, they like this lateral approach. You can get a bigger graft in. It has slightly higher fusion rates, so they prefer it. And somebody else gets to do all the opening and closing. So if you have somebody that you trust and work with often and can work the schedules together, you actually end up doing quite a few of these.
I
So
see.
Dr. Kitchen is our access surgeon. Does a
Dr.
lot
Kitchen?
with us. Yep.
That's a cool name.
So
So, I know you mentioned that there's a lot of surgeon preference, and then there's, available companies and so on. What would make you choose this over, let's say, an XLIF or PLIF?
So, well, one, I don't have the company on whatever you call it,
Like on contract?
approved through the hospital. Yeah, on contract through the hospital to do the XLIF.
Mhm.
We don't have new invasive
Mhm.
here on contract. So that leaves me with the DLIF through Medtronic. And so, but personally, as a functional neurosurgeon, I don't do these anymore. I choose not to do these. If I think that they need that, then I'm going to send them to one of my partners. But something that makes me think that is somebody that's at high risk of pseudoarthrosis, so they're obese, they smoke, and they have osteoporotic bone, you're going to want as big of a graft across there as possible. They also need to be young and not like super frail, because this is a two-stage surgery, so you're looking at anesthesia twice. A lot of times, though, there's people who now are doing it all in one stage, like where I trained Dr. Kazemi would do it all in one stage, where he would put it in here and the resident would be in the back putting in the screws and rods. So you can do it all in one stage, or most people do it in two stages.
Oh, very cool.
All right. Then we have our last one. Go. And that's the ALIF. So this one is definitely a vascular surgeon, comes in and gives you access. You have a big midline incision typically, and they move the peritoneum up. So this is only for use at L45 or, sorry, L45 or L5S1, and it depends on the angle of the pelvis if you can really get in there. A lot of people that have a very downward angled pelvis, you can't get to the angle with your inner body. So you have to look at that. And then the vascular surgeon comes in and they move the peritoneum up, and then they go between the aorta and the IVC, or the iliac arteries and the inferior vena cava. So that's why it can only be done here at 4-5 and 5-1. You have to make sure that they've already split off, and then you get there. And again, this is one that you can get a nice big graft in there and get indirect decompression with, especially somebody that has a very collapsed 4-5 or 5-1 disc, and they're having more discogenic pain, then this is a nice surgery for that. And you put the inner body in there, and those inner bodies are actually made with a screw that goes up into the vertebral body above and one screw that goes down into the vertebral body below, and then that's all you have to do. It's all integrated into one device. So you just put two screws in, and it's a big graft there to really jack things up. And oftentimes that's all you need, because you're doing this for more discogenic pain at L4-5 or 5-1. So that's kind of the armoire of the common neurosurgical procedures. Now, scoliosis, deformity surgery, you can start getting into some really crazy stuff. But for now, I think this is a good start.
Yeah. I mean, this makes such a big difference, because I feel like, at least in the pain medicine realm, we're ashamed to admit that, I feel like a lot of pain docs just kind of lump all spine surgeries into just, fusion and decompression. And we rarely, unless you've had some sort of surgical training, you rarely take into consideration the unique considerations that go into each one of these different approaches, the unique like consequences. I didn't really realize that, with the that oblique approach or that lateral approach, that you're going through psoas, and they're going to have psoas type pain syndromes, which could really throw you for a loop if you're not thinking about, oh, this could be just related to the surgery that they had however many years ago. Yeah.
And so
Any other
also with the
questions?
ALIF, it really seems there's a lot of luck involved in terms of anatomical variation and whether feasibility of approach is possible, right?
Right. I wouldn't call it luck. Like, you better know it going in based off of the imaging. Now, sometimes you're still surprised. I've had to abandon an ALIF twice because though the veins had split off, what you couldn't see on the imaging was that there was another small vein that was coming across the disc space. And as we were doing the discectomy, we actually injured that vein, and so thankfully you have a vascular surgeon right there, and he was able to sew it and repair it. But every time we kept going into the disc space, it kept trying to tear that vein, so we had to abandon ship, close them up, bring them back the next day, and go for posterior
Right. So
approach.
what does surgical planning look like in terms of determining candidacy for an ALIF? I mean, in terms of imaging and things like that.
So typically you can tell from the MRI scan, you're going to look at where the vessels branch off. If they branch off up above the level that you're wanting to treat, that's a good sign. And then you have to look at the angle on x-rays typically. If you look at a lateral x-ray and you look at the L5S1 angle, if that's where you're going for 4 or 5, in relation to where the pubis is, because the pubis is going to be the limiting factor for getting that angle.
Gotcha.
I guess the other risk factor with an ALIF that we haven't talked about in males, you have to really talk to them about it. They can get retrograde ejaculation because the sympathetic plexus is right here in front
Right
of the
there.
spine at this level.
Yeah.
And so if you injure that, they can get retrograde ejaculation.
Interesting. I was reading about something called like tantric sex theory, which is, kind of far out there, but they talk about ways to voluntarily have like retrograde ejaculation. It's very interesting.
All
They just
through
need to sign up for
sympathetic mediation.
Oh,
Yeah,
yeah.
that makes sense.
Amazing. So I have a question for you. You mentioned functional neurosurgery. I've noticed there's a trend, and I'm not trying to downplay this at all, but there's a trend to put the word functional in front of a lot of things. What does functional neurosurgery mean?
So stereotactic and functional neurosurgery is stuff like deep brain stimulation and spinal cord stimulation to restore function to patients with neurologic disorders or pain. That's why they call it functional, is we're trying to restore function. So I do deep brain stimulation for Parkinson's disease, essential tremor, dystonia, MS tremor, Tourette syndrome, obsessive compulsive disorder. They're looking at research-wise for depression, anxiety, eating disorders, and then spinal cord stimulation. I'm currently just doing it for pain, but there's a lot of research in doing it for people with spinal cord injury and trying to restore function. And I think it's the Vanderbilt group are actually making some pretty good headway with that. They've got patients that have had chronic spinal cord injuries with lower extremity paraplegia, and they're getting them standing with the stimulation right now and taking a few steps. So I think we're
that's
pretty
incredible.
close
We actually had someone during my neurology residency who was an SCI patient at the VA who had spinal cord stim placed in for radiculopathy, but he was wheelchair bound because of chronic weakness. And once he was stimulated, I mean, it was night and day. Stimulator was on, he was standing. Stimulator was off, he was sitting. It was remarkable.
Yep. So, I also do
really cool.
backlift and pumps. I don't do pain pumps unless it's for cancer. Y'all probably do a few pain pumps, but I only do it for cancer.
For cancer pain.
Yeah. And I don't do the titrations. They have to have a pain physician that's willing to do all their refills and titrations.
Yeah.
I just
But James,
That's
don't
time
have time
consuming.
in my clinic.
Yeah, Dr. Pinckard-Dover could tell you the deep brain stimulation gaze as an anesthesiologist. I mean, it's it's really honestly fascinating. It's a true multi-specialty situation where you're doing an awake cranny, right? You have the PhDs in the room, you have the surgeon in the room, the anesthesiologist in the room. These are where you see those those viral videos of awake brain surgery and someone playing the saxophone, and that's
Yeah.
that's the dramatic version of it. But it is really a fantastic experience, especially with
My
those outcomes of it.
my first like away neurology rotation was at the University of Florida with Dr. Oken and he was a neurosurgeon. His name is escaping me right now.
Foot.
It's been a while.
Kelly
Dr. Foot, yes, yes. And I watched them
With the
do a
hair.
deep brain stimulation. He did have magnificent hair, and they did a DBS for essential tremor, and it was moving. I think it was the most moving thing I've ever seen in medicine. I mean,
Yeah,
you have the patient
Yeah.
draw a spiral on the sheet of paper, and it just looks crazy because they're tremor. And then while they're testing, granted, there's that initial lesion effect, but the tremor just disappears, and the patient breaks down in tears, and it's just a whole, we all sing hallelujah. It's amazing.
it really
Yep,
is.
that's what I get to do every Friday.
That's awesome. Well,
That is
thank you
pretty
so
cool.
much. That was a really, really good conversation and talk. It
you
was
for
really
having me.
educational. Thank you so much for that.
Put our virtual hands together.
I had good questions. Made it more
Yeah, thank you.
interactive. So.
If
Anybody
you're
else
up
have
if you're
questions
up
in the
for it
audience?
at some
Uh-oh. I think you muted yourself.
Well, I was going to say, if you're up for it in the future, we'd love to have you back to talk a little bit more functional neurosurgery. Whenever you have the time, we can always
Okay.
talk about it, but it would be a fantastic conversation to have on the stage.
Yeah.
Yeah, no, I would love to. It sounded like y'all were wanting more spine stuff, so I put together general spine talk for this one, but I'd love to come talk DBS. You might not get me to shut up.
We're
That's
actually,
great.
we have kind of an initiative coming up next year where we're doing a series, like a 3 or 4 week series that's focused on a certain topic. And right now we're trying to build out our neuromodulation series. And I think it would be amazing to have your perspective and to have you as a return visitor, just to be acquainted with the space and how everything works. That would just make it amazing.
Yeah, no, I'd love to join you.
Awesome.
Just tell me when.
Awesome.
Awesome. Well, thank you so much again. Thanks,
Yeah.
everyone.
Cool.
All right.
And
It's time for
we're
dinner.
gonna post. Yeah, it's time for dinner. We'll post the YouTube video tomorrow, and everybody that's here will get kind of like a post-event survey. If you wouldn't mind filling that out, it gives us valuable data how to make us improve, smoother, better, more interesting. So please fill all that out.
Yeah.
All righty. Have a good night,
Alrighty.
everyone.
Good night, everybody.